Good morning. My name is Larry Brandt, and today I have the pleasure of interviewing James Barthel from the Moffitt Cancer Center in Tampa, Florida. And he and his colleagues wrote a very interesting article for GIE, and it has to do with the whole difficult issue of patients who have esophageal adenocarcinoma that, as you know, arises usually from Barrett's epithelium. Well, what happens after you treat these patients with definitive chemoradiation? Sometimes, often, the Barrett's epithelium that led to this esophageal adenocarcinoma persists. How do you treat that? What's the best way to treat it? And here James wrote a very interesting paper on cryoablation of persistent Barrett's epithelium after definitive chemoradiation for esophageal adenocarcinoma. So with that as an introduction, Dr. Barthel, why don't you tell us what the genesis of your idea was? What hypothesis did you have? And just summarize your findings briefly for us, and then we'll ask some questions.
Well, this comes from an earlier study that we did where we found that almost all patients who receive chemoradiation therapy, whether it's definitive or given as neoadjuvant before surgery, have persistence of the Barrett's esophagus that led to the cancer in the first place, and the dysplasia. The chemotherapy and radiation seemed to do nothing to that. So we became very concerned about what was happening in the patients that received definitive chemoradiation therapy, meaning that they were not treated with surgery. Once they have esophagectomy, that effectively removes any persistent Barrett's, so it's less of a concern in the surgically treated patients. But in the patients who are treated with definitive chemoradiation therapy, the Barrett's is still there. And so we began a program of endoscopic surveillance on these patients, and in the course of doing that, it dawned on us that perhaps we should proceed with ablation therapy just as you would for patients with dysplastic Barrett's who have no history of prior adenocarcinoma of the esophagus. And so we explored various methods of performing ablation. We looked at the possibility of performing photodynamic therapy, but there is significant complications reported in the literature, and that was our own experience in attempting to do that in the radiated esophagus. We explored the possibility of using radiofrequency balloons, but the manufacturer has listed that as a contraindication to their use, previous radiation to the esophagus. And we were aware of work published by Dr. Greenwald that suggested that you could use cryotherapy as salvage therapy in the previously radiated esophagus, and that had been our own experience that it would work, and so we did that.
Let me cut you off on that and say, okay, so now you got cryotherapy, right? Tell me the results and what you did. And this sounds like a very interesting idea because it gives you the opportunity to determine whether or not the Barrett's esophagus that persisted was the cause of recurrent or led to recurrent cancer, or whether or not the cancer that developed in these patients as a recurrence developed just as a primary site cancer.
A metachronous cancer.
Metachronous cancer. So it's a wonderful study. And tell us your results.
Well, what we did is we looked at, in this paper, the safety and efficacy of cryotherapy in these patients with prior radiation and chemotherapy, not undergone surgery. And our endpoint was a decrease in the PROG classification and downgrading of the dysplasia status.
What is a PROG classification? Can you tell our...
PROG classification is a standardized way of measuring the length of a Barrett's segment. It's first published by Dr. Sharma in 2006, and it involves measuring the amount of circumferentially involved esophageal wall with Barrett's, and then the maximal extent of the tongues or columns of Barrett's that are present. So you have two numbers that are generated from this, the maximal extent of contiguous Barrett's, which is the M part of the PROG classification, and then the circumferential extent of contiguous Barrett's, which is the C apart. And so
I think it was 2004.
Was it 2004?
Not
I thought it was
2006,
2006. But
so give me the results here.
Okay. Well, so we found a significant reduction in the PROG classification in both the C and M measurement, and we found also a downgrading of the dysplasia status. In 3 of our patients, we were able to completely eliminate visible Barrett's, so their C and M measurements basically fell to 0, and also we were able to show that biopsying along the columnar aspect of the neosquamocolumnar junction produced no histologic evidence of dysplasia. You still see some focal intestinal metaplasia, but not dysplasia.
So you're using cryotherapy after chemoradiation, and you're getting a downgrading of the Barrett's epithelium, or even reversal of the Barrett's epithelium. A lot of people don't have cryotherapy. Can we use APC?
Well, APC to treat the thing, well, let me back up a bit here. First of all, in our...
Back up briefly, though.
Back up briefly. I know I'm wordy and I apologize.
Okay.
The amount of Barrett's is unchanged. So if they start out with a 6-centimeter segment of Barrett's with an adenocarcinoma, stage 2 or 3 adenocarcinoma rising in it, and get definitive chemoradiation therapy, what we found in our original study was that they still had a 6-centimeter segment of Barrett's after the definitive chemoradiation therapy. So you have a lot of Barrett's to treat with something like APC. And the problem with APC is that in the radiated esophagus, it has a very high complication rate, and it was the APC data, which I believe led the radiofrequency balloon manufacturer to restrict the use of that device in the radiated esophagus, because both are electrothermal techniques, and the heat aspect of that behaves differently than the freezing aspect of the cryo.
All right. What do you do with nodular Barrett's?
Well, in the radiated esophagus, we've been reluctant to do EMRs, although I do know of some people who have successfully done that. So what we do is we usually give a third freeze interval, a 20-second freeze interval directed at the nodular mucosa. Our treatment protocol that we settled on in this paper involved giving 2 20-second freeze intervals in a segmental fashion to the persistent Barrett's as treatment. And if there was an area of nodular Barrett's within the particular segment we were treating, we would give a third 20-second
You just treat it more.
Yeah, just treat it more. That's
so we have only about 30 seconds left. So in 30 seconds, which I know it's difficult for you to do, but in 30 seconds, see whether or not you can tell us when we should use this technique.
Well,
go.
I think that every patient that gets definitive chemoradiation therapy should be looked at 3 to 6 months after the therapy endoscopically, and if indeed they have persistent Barrett's, which our data suggests all of them will, they should undergo ablation therapy, because they will get a metachronous cancer arising in the Barrett's within a year or 2.
And if you treat them, you can expect them to get resolution of their Barrett's, or improvement of the Barrett's, a shortening of the Barrett's, a general improvement which might diminish the development of cancer subsequently.
This is a new way of thinking. We don't think these cancers are recurrences, in that the primary therapy, the chemoradiation therapy, has failed to get rid of all of the cancer and we can't detect it clinically. We believe that these cancers are actually metachronous cancers, and that's what's accounting for primary site failure in the definitive chemoradiation therapy, not the traditional oncologic definition.
Thank you very much.
All right, thank you.
Okay.